This section is pelvic health for the PTA. We're going to start out with a basic review of pelvic anatomy and different types of pelvic dysfunction. So the learning objectives are to be able to describe several common pathologies or dysfunctions that pelvic health therapists treat, to outline basic treatment strategies and common dysfunctions and the treatments that a PT would delegate to a PTA, to demonstrate the ability to teach basic pelvic floor muscle exercises to the patient as directed by the primary PT, and to state several observations or patient subjective reports that might indicate the consultation with the primary PT for a possible referral to a pelvic health specialist. So you do not have to be a pelvic health specialist unless that's an area that you want to go on in, and we'll talk about continuing education. However, we can do a lot of interventions that can help people in this area without being a specialist, and I'll talk about it in that light, and we'll practice some things in the lab. So, pelvic health physical therapy is a specialized area of therapy that focuses on pelvic floor dysfunction. So a lot of I'm going to go straight down to the bottom. Common misconceptions is that it's only for women. And in fact, when I was in school, it was called women's health. It's not just for women. Everybody has a pelvic floor. It affects all genders. Another common misconception is it's only for postpartum women, and that's not true either. It affects all ages, from pediatric to geriatric, everything in between. Another common misconception is it's too embarrassing to discuss. Well, this is professional medical care. We a lot of times are discussing things that don't get discussed in any other areas, and we'll talk about communication and patient education. It's really important. So, pelvic health addresses conditions affecting bowel, bladder, sexual, and reproductive function. It's a growing field with increasing recognition and demand. It requires specialized training and certification. So just having this one day, one lab with pelvic health is not going to make you an expert. It's just going to give you an introduction. It might be something you want to pursue in the future. Some of our students get the opportunity to work with a pelvic health specialist in the clinic during their final clinical assignments, and that's great if you get to do that, but it is not something that's always available. So maybe this is an area that you want to get specialized training in because you want to make it available in the clinic where you work, which is great. It's a really nice specialty. So basic pelvic anatomy review. Key structures, the pelvic floor muscles, the ligaments, fascia, and connective tissues supporting. We're not going to talk too much about all the specific pelvic floor muscles, but take a look at Complete Anatomy or something. You'll see there's a lot of them, but they all work together as a group. That's why we're not going to talk so specifically about each individual one. The organs, the bladder, urethra, rectum, the reproductive organs. There a lot of the innervations through the pudendal nerve and sacral nerves, S through to S4. Pelvic floor does a lot of stuff. It supports our pelvic organs, our abdominal viscera, or as I say, it keeps your guts from falling out on the floor. But so it supports your pelvic organs. It maintains continence through sphincteric control. It has some sexual function. It's a stabilizer of the core, and it has a respiratory function. And we'll look at how it coordinates with the diaphragm to sump pump to sort of keep pressures equal. That's kind of its job in the respiratory system. So the joints involved in the pelvis, the sacroiliac joints, have about 2 to 4 millimeters of movement, so not very much. 3 or 4 degrees of movement, if you want to think of it in terms of degrees. Gymnasts or dancers may have more, and you'll see the kind of range of motion they have. It's more than what a regular person has. During pregnancy, you might have more because the pregnancy hormones circulating in your body make your ligaments more flexible. So the pubic symphysis is that amphiarthrotic joint with the little fiber cartilaginous disc to absorb forces. The hip joints, we know those hip joints and all the stuff that goes with them. And then the L5 S1 articulation. It's all part of the pelvis. So the pelvis is the bottom of the pelvis is that open. We've seen the skeletons in the lab a million times, right? It's open. And so we need the pelvic floor. It's a complex structure that closes the bony pelvic outlet and its muscles and ligaments and fascia. So the muscles are 70% slow twitch because they have to kind of work all the time. There are endurance muscles. They contract, relax, and bulge. The piriformis and the posterior wall of the pelvic floor attaches at the anterior surface of the sacrum and the ilium near the PSIS. The obturator internus forms part of the anterolateral wall of the pelvis and attaches from the structures around the obturator foramen and the inferior pubic ramus and the ischium. The levator ani is a broad sheet of muscles made up of thicknesses identified by their attachments. So the ischial coccygeus attaches from the ischium to the coccyx. You get the idea. The fascia covers the pelvic muscles and covers the pelvic diaphragm. So we have the fascia kind of connects it all together, and they all work together in a system, but it's not an isolated system. It works together with other muscles. So we'll talk in therapy a lot about the abdominal canister. And what the heck do we mean by that? So if you think of your torso as like a can, like a can of soda or any kind of can or canister, like a cylinder that has a top and a bottom and sides. So the abdominals, the transverse abdominis, external obliques, internal obliques, rectus abdominis, those form sort of the around the sides around the canister. The pelvic floor is the bottom of the can. The multifidi are kind of sewing the side together. So the multifidi are almost like the seam on an aluminum can, if you want to think of it that way. And then the diaphragm is the top of the can. So we have this nice little contained abdominal canister, and a lot of those muscles function together. They function together in stabilizing the core, in that sump pump activity with the respiratory system, and maintaining the pressure in our abdominal cavity, which is important for the function of a lot of our organs. So common pelvic health conditions that you'll see, and we'll talk a little more in detail about some of these. Usually it's either underactivity or overactivity. Either the pelvic floor is underactive, it's weak or something's going wrong with it, or it's overactive, it's too tight and it's not relaxing like it needs to. The third thing is it's non-functioning. So we'll talk about that as well. So underactivity includes incontinence, and there's several different kinds of incontinence. Stress incontinence, which is activity related. So if somebody coughs or sneezes and it causes them to void urine, or they when they stand up out of a chair or something like that, that is stress incontinence. Urge incontinence is a sudden strong urge. That's when you just got home from the grocery store and you can't throw your grocery bags down fast enough to run into the bathroom. That's urge incontinence. Mixed means there's a lot of things going on. And fecal incontinence is when you can't hold in your fecal matter. So the pelvic organ prolapse is any kind of any time when your abdominopelvic organs are being dropped down from their normal position down into the outside. So the symptoms of pelvic organ prolapse can be pressure, heaviness, or incomplete bladder emptying, because the pelvic organs pressing on the bladder can make it difficult to completely empty the bladder. For overactivity, a lot of pelvic pain conditions cause overactivity. And in the textbook, you'll see where they talk about how to down train the pelvic floor muscles. We're going to talk more about that in lab. So pelvic pain conditions can cause pain or aching in the pelvis, buttocks, or perineum, constipation or difficulty emptying the bladder, or pain during sex or pain during voiding. And with an overactive pelvic floor, you can have difficulty emptying the bowel or bladder. A non-functioning pelvic floor can either be caused by shortened, overcontracted muscles. So that's almost like extreme overactivity, if you want to think of it that way, or neuromotor impairment. So you had a spinal cord injury, or you had a stroke, or you had something that is causing those muscles not to function because of a neurological problem. So we'll talk about some special populations, but one special population is pregnancy and postpartum. And there are several different things that might be associated with that. Diastasis recti, where the rectus abdominis is separated at the linea alba, the two sides of it. Pregnancy-related pelvic girdle pain, postpartum recovery issues, or recovery from a C-section. Those are all, special conditions. Other conditions that are considered special population: constipation, bowel dysfunction, lots of different reasons for that. Interstitial cystitis or painful bladder syndrome. Post-surgical rehabilitation could be a C-section, could be a prostate removal. Pediatric and geriatric consideration. So like I said, pelvic floor dysfunction can affect people all across the age spectrum from pediatric to geriatric. And we'll talk about special populations in one of the other lectures. So risk factors for pelvic floor dysfunction include low back pain, so chronic low back pain we're talking about, lumbo-pelvic or abdominal surgery of any type, prostate issues, enlargement or surgery, trauma or abuse, depression or anxiety, neurological conditions like MS, CVA, Parkinson's, all your favorites. High impact activity, prolonged sitting work or prolonged cycling. Like maybe you're a road cyclist, you're on the bike all the time. Childbirth, so either vaginal delivery or C-section delivery can cause pelvic floor dysfunction, or can put you at risk for pelvic floor dysfunction. So as PTAs, what can we do? So under PT supervision, we can do external manual therapy techniques. And we'll talk a little bit more about what those are. But therapeutic exercise instruction and progression, biofeedback assistance. So the PT is going to tell you where to put the surface EMG, and you are going to place the electrodes. So that's basically the assistance that you're going to provide. And we'll talk about that in lab as well. Patient education on their prescribed programs and modality application as directed by the PT. Outside the PTA scope of practice, PTAs do not do internal pelvic examinations in the state of Washington. Might be different in another state, I don't know. But PTs can do that. Initial evaluations and treatment planning as usual with everything. Or intravaginal or intrarectal interventions, we don't do those either. So that's our scope of practice as PTAs. So the PT, when they evaluate someone for any sort of pelvic floor dysfunction, they're going to get a complete history: gynecological, musculoskeletal, surgical, digestive, bowel and bladder. They're going to screen for bowel and bladder function. They're going to observe the patient's posture, the patient's breathing pattern, their ability to perform pelvic floor contractions, trunk and lower extremity examination, including all the usuals: manual muscle testing, range of motion, single leg stance, functional assessments. So when a PT is doing an evaluation, no matter what it's for, they do all those things too. A pelvic floor examination, if somebody's there specifically for pelvic dysfunction, is performed by observation, external palpation, surface electromyogram. So the regular kind of electromyogram, they actually put electrodes in your muscles. Surface, you use the electrodes like we use for electrical stim. Real-time ultrasound to observe the structures, or internal muscular assessment. So it's not to say that they would necessarily, a pelvic floor specialist would do those. A PT who's not a pelvic floor specialist would probably do the evaluation to that and then refer to a pelvic floor specialist for that last part. So for PTAs, we need to be able to review PT evaluation findings, understand what the baseline measurements are, what they mean. We need to be able to monitor patient progress indicators and recognize changes that require PT consultation. So there's some common assessment tools for pelvic floor. One of them is called the Pelvic Floor Distress Inventory. The PFDI 20 has 20 questions. The International Consultation on Incontinence Questionnaire, visual analog scales for pain, functional movement assessments, and the Kazan Pelvic Dysfunction Screening Protocol, which is pictured here, and it is in your lab manual, and we'll practice using that in the lab.